Welcome back. Our second keynote speaker is Dr. Harold Pollack, who is the Helen Ross Professor at the Crown Family School of Social Work, Policy, and Practice at the University of Chicago. He is the co-founder of the University of Chicago Crime Lab, co-director of the University of Chicago Health Lab, and a committee member of the Center for Health Administration Studies at the University of Chicago. His current National Institute of Health-funded research concerns improve services for individuals at the boundaries of the behavioral health and criminal justice systems, disabilities, and two major new efforts to address the opioid epidemic in Illinois and across the nation. It is my great pleasure to welcome Dr. Pollock.
Hi, I'm Harold Pollock. I'm the Helen Ross Professor at the Crown Family School of Social Work, Policy, and Practice and co-director of the University of Chicago Urban Health Lab. Delighted to be with you today. Thanks so much for giving me the opportunity to be with you. I want to talk about some of the work that we're doing on how to prevent the next 911 call, really how to improve services for people who are at risk of a mental health or a behavioral crisis. And I should say this work is supported by NIMH, and we're very grateful for that. I should also say that I'm not by any stretch the smartest person in this room, and quite a number of people listed here are important collaborators in this work. Andrea Tentner with the data science, along with a whole series of doctoral student collaborators on qualitative and quantitative work, outreach workers, Jessica Smith-Atassi and Luberta Livingston, data scientist Zubin Jelba and Xander Bieberman, a number of people that are involved in just the mechanics of getting the data that we need and making sure that that we can have the proper relationships with the organizations that we work with so that we can do our work. And very grateful for all my collaborators in this work. So it's certainly not me alone presenting the work that I'm talking to you about today. So here are some themes for the next 3 hours, maybe the next 3 days. I want to start by describing the nature of the challenge a bit, talk about some Chicago street scenes, some first responder calls that we've had in Chicago, then talk about something that happened in a Maryland movie theater, and then something that happened on a United flight at O'Hare Airport. I'll talk about how we try to identify people at risk of behavioral crisis, for want of a better term, which is the term behavioral crisis really describes a diverse set of interactions where someone doesn't respond in ways that are expected or desired by first responders or by others. We'll try to give the mundane realities of emergency response their due. A lot of the public discourse around 911, police response, deals with big issues, big structural issues, big policy issues. Very often the mundane realities that police officers, that EMTs and others face in their daily jobs is actually way more important in some ways than the big issues that we talk about in policy discourse. I'll talk about person, place, and event-based strategies that we use to try to improve emergency response and follow-up. And I'll talk about some of the opportunities and challenges that we face when we try to use linked 911 data, police data, ambulance administrative data to identify people, places, and events where we might productively intervene. Then we'll compare two different strategies to try to find people who might be at risk and who we might help. One is what we call a high utilizer model, or sometimes it's called a frequent flyer model, something like that. People that demonstrate high use. There's the people who had 42 911 calls that involve police. And can we identify a core of people that way and see if we can intervene? And that's sort of the most natural thing that many of us think about. But there are other approaches too, and we use big data, predictive analytics, machine learning type approaches to try to identify and help vulnerable people who are at risk of a behavioral crisis, but maybe haven't had one. Or haven't had one that involved police and so on. And then I'll close by noting the necessity, but also the limitations of improving first response as a way to help the most vulnerable people that I'm talking about in this presentation. Let me start with the challenge facing first responders. There's been a lot of prominent tragedies that involve first responders and individuals in behavioral crisis. Sometimes these crises are the result of serious mental illness, but they can also result from acute intoxication, from intellectual or developmental disabilities that have a behavioral component, or from other causes, maybe sometimes the medical complications of diabetes that lead people to behave in an unexpected way, to be non-compliant with instructions, to be verbally aggressive, or to be escalating in other ways, or to be behaviorally dysregulated. Now, I should say in my talk, I don't have any videos, but some of the discussion does involve describing some pretty upsetting violent incidents that involve vulnerable people. And so there's no harm or no foul if you want to go get a cup of coffee and check this out another time, or at least step away for the next 5-10 minutes. This is difficult stuff. My wife and I care for her brother. He lives with something called Fragile X syndrome. He's a 260-pound man, and we often think about what would happen if he had a behavioral crisis, and it's this is tough stuff. So I just wanted to share with you that if you want to step away for a little bit, that's okay. So here in Chicago, unfortunately, we've had some national headlines around some tragedies that resulted from these types of encounters. Probably the most famous one involved the shooting of Laquan McDonald. Laquan McDonald was a teenager who had a series of personal challenges, who was walking in the roadway. He had a knife, although the only thing that was harmed with his knife was he slashed a tire, in a car. But he was being followed from a distance by police officers who were trying to figure out how to help him. There's actually a video of this long encounter that they had with him, which could have been in a police training film of how to do it right when someone's in a behavioral crisis, until Officer Jason Van Dyke drives up and fires 16 shots and murders Laquan McDonald. And that of course made national headlines. A second incident involved a young man named Quintonio Legrier. He was having a psychotic episode, and he was actually trying to get at his father, and he had a bat. And both Legrier and his father called 911 multiple times, and the 911 operator actually hung up on Quintonio Legrier, who was having a paranoid episode. Eventually, the police did come to the scene, and an officer shot and killed Quintonio Legrier, and actually also Beatty Jones was also killed in in that gunfire. And after the fact, this was a very, very contentious case, and you can imagine the reaction. The officer who killed Quintonio Legrier, Quintonio Legrier was charging at him with a baseball bat. And if we had a time machine, many of these incidents we could handle better than an actual human being in the moment facing a very frightening situation. And one of the things that I have learned in my work in this area is to appreciate the humanity on all sides in these very difficult encounters. I served on something called the Police Accountability Task Force in Chicago on the Deescalation Working Group, where we looked at ways we could improve police training, improve procedures in a variety of ways to try to make events like this, less likely to happen. And it was a very powerful experience for me to be in this work. Let me tell you another story that is also emblematic of the challenge. This young man named Robert Saylor, he actually lived with Down syndrome, and he was in his 20s, and he goes out to the movies with a young woman who was his sort of caretaker, and the movie's done, and he walks out into the lobby of the movie theater, and he gets very agitated. And the young woman calls his mom, and she says, he's really agitated. What should I do? And his mom says, why don't you go get the car, pull it around, maybe he'll calm down, and I'll come down to the theater, see if I can help. So So the young woman goes, gets the car, and when she comes back, Mr. Saylor had gone back into the theater and he had sat down in his original seat. He was agitated because he wanted to see the movie again. And, you know, he can't do that. He didn't pay for a ticket. And so the manager of the theater comes over and he starts getting into it with him. And he says, you know, you can't do that. You got to buy a ticket. And things are getting heated. And the young woman shows up and she says, don't touch him. Don't, give him a little space. This is not going to work. And the manager basically dismisses this young woman. And, she's a teenager, basically, like she's not going to tell him how to do his job. He calls mall security. Mall security is a couple of off-duty police officers who come and they get into it with Saylor as well. And they basically communicate with him, you're gonna come with us and we're gonna make you come with us. And they start struggling with him and they pull him out of the chair. And he ends up on the ground with them on top of him. And his mother arrives to find that he has actually died, that he was asphyxiated. And it's very, very dangerous to restrain someone in a prone position. And particularly people with Down syndrome have some morphological vulnerabilities to that, but that is generally a very dangerous thing to do. And those officers had absolutely no intention to hurt this young man. They were actually charged. There was a homicide charge, and they said, "Look, we followed our training. Our training was to escalate to achieve compliance." And I have absolutely no doubt that that they did not bear Robert Saylor ill will. But obviously, that incident resulted in a tragedy. Another incident. Fast forward. Dr. David Dao at O'Hare Airport. This was a story that was on national news. He was on a flight that was, I believe, overbooked. And the police came on and they said, you got to, your ticket's not good. You have to get off the flight. And he refused. And the police ended up dragging him out. And they heard him when they dragged him out. And this got national news. And I think the major theme of national news was, wow, United service is really terrible. Why did they drag him off? His ticket was valid or his ticket wasn't valid, etc. I don't care whether his ticket was valid. On the surface, what could be more different than Robert Saylor's situation and David Dao's situation? On the other hand, it's of course exactly the same scenario. There's a man in a chair who is being non-compliant, and that's actually very dangerous to drag someone out of a chair, and someone got really badly hurt. Imagine if the officers in that instance had said, Dr. Dao, we're not going to manhandle you. You may never be able to fly United again if you refuse to get off this flight. Because there's someone else here that would just take $500 to just trade places with Dr. Dao because he's being a jerk and he's not getting off the plane. Imagine how different that scenario would have worked out. So one of the things that we focus on in some of our work is how to improve police training, and particularly de-escalation training. One of the striking things about this training is much less focus on recognizing specific conditions and more on applying time, distance, and cover principles to broad situations. If you encounter Robert Saylor and you're a police officer, you're really not going to understand why he's responding the way that he did to you. But you can understand he's a man sitting in a chair who's being very defiant. And if they had just waited, his mom would have arrived and she would have bought him a ticket and everything would have been fine. Or she would have convinced him that he had to leave. You keep physical distance from the person so no one's fighting, no one's getting hurt. And you might need to take cover. In the case of Quintonio Legrier, the officer who shot Mr. Legrier would have been much better off if he had retreated and found an obstacle that would have protected him from this young man who had the bat. Time, distance, and cover, way more valuable than any specific diagnosis or specific tactical insight into a real-world situation. Part of the training that we also focus on is whether particular venues where there's a high risk of something like this happening, can you train the staff to do a better job? Group homes, the bus station, places like that. If you're going to call the police, what do you tell them? We spend a lot of time on things like this. In particular, we focus on 3 different kinds of interventions that seem to be helpful in different contexts. One is what we call person-based interventions. So if you can identify a person at risk, you can see if you have some services that you could offer that person that might be helpful. Some interventions are mental health interventions, like assertive community treatment. And there's a criminal justice version of that called forensic assertive community treatment, where you go out to the person and give them mental health treatment that they're probably not going to get if you ask them to come and show up at a clinic at Tuesday at 3 o'clock in the afternoon. Or maybe people need housing, or they need other kinds of care. Maybe they need physical health care. That's a person-based intervention. Harold's at risk. What can we do to help Harold? It's also event-based interventions. Are there particular scenarios? Someone calls 911, particular words are used where you say, you know what, I think this is a mental health crisis. Let's send out an officer who has good mental health training. Crisis intervention teams, crisis intervention training, CIT is the term that is usually used, where you want to send an officer out who's been specifically trained for people that are more likely to, to manage situations where people might have a mental health crisis or a related crisis. And there's also place-based interventions. We can go work with the staff at the bus station, at the homeless shelter, and other places where we think there's a predictable risk. We can also work with people in their own home. There's something called Smart 911, which is very helpful. Suppose that your first language is Vietnamese, and you have a son who is vulnerable to a behavioral crisis. You can actually register with Smart 911 so that when you call 911, something comes up on the computer screen of the operator that says, this person is speaking Vietnamese. Because of course the operator may not know the difference between Vietnamese and other East Asian languages when she's just hearing it. And with that information, she can get you quickly to someone who speaks the proper language to find out what your emergency is. Or maybe the Smart 911 says, my daughter has autism, and if you come to our home, please turn off the sirens, because that's just going to get her more agitated if she hears the siren. And of course, we look a lot at whether those people, places, and event interventions overlap. I mentioned at the beginning, we want to give the mundane realities of first response their due. Let me give you two examples. I think a lot of police officers understand very, very well we want to use the time, distance, and cover. We want to be humane to people that are having a behavioral crisis, but it's often very hard to do given the realities. One of the most basic realities is just how busy people are. I'll give you an example. Suppose that it's 2 o'clock in the afternoon on Tuesday, and I'm in Uptown in Chicago. That's a pretty low crime part of Chicago. And I'm standing in the middle of the road, and I'm telling Jesus to fuck off, and Jesus is arguing with me. And a bunch of people are looking at me, particularly, of course, as a middle-aged white dude with a lot of gray hair. It's pretty obvious what's happening. This is a guy who has serious mental illness. I mean, could be that I'm actually arguing with Jesus, but most of the time that's not what's happening. But most importantly, the police there, they can take 45 minutes to calm me down and to get people there to help me, to take me to a mental hospital, do what has to be done, because there's not a whole lot of other things happening that are emergencies at that same moment. One of the stories that we heard on the Police Accountability Task Force was a woman who was a CIT officer, and she was called to someone's home. He was sitting on his bed, and he was having a psychotic episode. He needed to go to a mental hospital. And she's talking to him, and she's really doing a great job calming him down, trying to get him to come with her in the police car to the mental hospital. But it's a Saturday night in one of the highest crime areas of Chicago. And while she's talking to this man, her cell phone is going nuts. And her supervisor is standing behind her. His cell phone is going nuts. We need you here. There's an emergency in this other place. There's a shooting over here. And at some point, her supervisor runs past her, tackles the man, and basically it was like, I had to wrap this thing up. I just didn't have 45 minutes on a Saturday night in this police district, to give you that time. And I'm sure that he would have wanted to, but he just couldn't. There were other emergencies. And when you think about issues like defund the police, one of the real challenges that we have in making that real is making sure that some of the very humane policing practices that we definitely want first responders to follow, they're pretty labor intensive. They take a lot of time and manpower. We want to make sure that the people have that time and manpower to do this properly. So giving the mundane realities the first response their due is just really important. So now let me tell you about how we try to use administrative data in Chicago to identify vulnerable people that we can help. And as I mentioned at the beginning, we're trying to predict who is at risk of a behavioral crisis, one that involves first responders. And we use two different methods which compare their strengths and weaknesses. One is the traditional sort of frequent flyer high user model. Who has had a lot of these encounters in the past that we could identify and then reach out to and try to help. And the second is using sort of big data, machine learning, predictive analytics. Can we identify people maybe before any 911 call that looks exactly like this is made? And we use what's called random forest methods that some of you may be familiar with. What are the strengths and weaknesses of these different approaches? So we actually published in the American Journal of Public Health a descriptive analysis of high users that we found in 2016 and 2017. And you can see the full team that Andrew Tentner was the first author on this, and many other people that I mentioned at the beginning are co-authors. We went and we examined quite a large number of people and just looked at who are the top people. What was interesting was when we looked at our top 10 utilizers, our top person had 42 emergency events, 37 behavioral health events that involved at least the fire department. And he was arrested 5 times, 2 felony arrests, and 3 misdemeanor arrests. But most of the people that we looked at, a bunch of them were arrested a lot. There was one, number 3 was arrested 14 times. Almost nobody here was arrested for a really serious felony in our data set, for one obvious reason. If you went out and committed an armed robbery, you're not going to be a high user because you're locked up. You can't be having another 911 call because you're in the Illinois Department of Corrections. So the kinds of crimes that that were bringing them in contact with police were sometimes serious or scary, but not super serious violent felonies, because otherwise they would be incarcerated. We also looked at the top 10 places. Homeless shelter, mental health facility, both of Chicago's major airports, and a lot of train stations. It was actually kind of funny that our first analysis, we went and we presented it to the first responders in the fire department. And there were 2 things that were just hilarious. One was we had this whole elaborate zip code analysis. We'd start saying, this zip code, there's just a lot happening in the zip code. And as we started to talk, at some point I took a breath and somebody raised his hand. He said, dude, there's nothing interesting about that zip code. No, none of the people that we get calls on in that zip code actually live there. That's just the end of the red line. Those are all people asleep at Howard Station or at 95th Street. And the other thing that was funny was we disguised all the individuals that we were talking about. And we start to talk about somebody, and then all of a sudden somebody would say, isn't that guy in the red jacket who's always on the blue line, sort of talking about the White Sox or whatever? Chicago's a city of 2.7 million people. It's a pretty small town when you start talking about the really extreme high users of 911. And it was really striking. People recognized a lot of our folk. And we really had to be very careful from a human subject's point of view not to reveal any information that was identifiable by people for whom this is their job, is to respond to these calls. And we found these high user models had some real strengths when we focus on those high users. One is we really could identify a core group of people that had really high rates of 911 calls and had a really high risk of having another one in the next 6 months. By the way, the most common reason for police to be involved was a survival crime, shoplifting alcohol or a pair of socks from the supermarket. And low-level offenses that would get them into it with security. I would say sometimes, by the way, these offenses, you might say, why are we even arresting these people? And that's my general reaction. Sometimes scary things did happen. There was a young woman who was continually shoplifting like crazy and getting arrested a lot or having encounters a lot. Usually it didn't actually end in an arrest, but had some sort of an encounter where she was kicked out of the store or something like that. Well, one time she was shoplifting and an 85-year-old shopkeeper came out and tried to prevent her from stealing his stuff, and she punched him in the face and he got hurt. These are potentially dangerous situations. And these high user models can identify people like that. They're simple and transparent, and that's a big plus. But they also have some really important limitations. One is, by definition, these high user models are not about prevention. People are already well in the midst of some really serious problems. So if you want to do prevention, these models are already, past that point. Also, there are people who have episodic crises that would self-resolve. So some of the people, they had a ton of calls and then none later, and they would show up in these high user models, but they're not at future risk. And also the high users have distinctive needs that don't always match the interventions that we have available. Very, very often the intervention that we have available is sending mental health providers out to help people with assertive community treatment, something like that. Well, if somebody has a really chronic alcohol use disorder, it's not exactly clear that that's really what they need or that that's going to be helpful to them, or even that any sort of Medicaid or other payer will pay for you to go out and do that service for that person. So when we turn to the machine learning and the predictive analytics, we sometimes found that that was working better. And also the machine learning told us things about people that were very helpful for clinical and policy interventions. Sometimes words came out that were in the EMT notes that really lit things up in our machine learning that we wouldn't have spotted if we were just looking at frequent flyers. This person was aggressive. That was very predictive of something's going to happen in the future with that person that you wouldn't get if you just counted how many calls they had. We also found that when we were trying to look at a larger population, not just the top 100 people, but maybe the top 5,000 people, that the machine learning seemed to do a lot better. But here's just the obligatory snazzy machine learning predictive analytics slide. When you look at one of these pipeline models, all of our students think they're going to show up and spend all their time way to the right on this diagram. So, should I be using random forest? Should I be using lasso? Should I be doing this model or that model? Let's go to the blackboard and start writing down a bunch of calculus. What you actually spend almost all your time on is way to the left in the sort of preparing the data and cleaning the data. So you have like Rob Johnson and John Robson were both arrested on the red line in the week of April 22nd. Is that the same guy? How many different ways can you misspell homeless? A lot of practicalities of data that's being entered by first responders who are sort of very busy in the moment, or someone calling 911 who's scared and giving a 30-second description, and the data, it's messy. You have to learn how to analyze the data and understand what the data is. And so a lot of folks on our team just spend a ton of time just trying to understand what is the data generating process and how do I understand how to make sense of what's here. And we had some really interesting interplay between our qualitative research and our big data research, just try to understand what do certain words mean? Why do people write them in the notes? We did a random forest classifier with about 400 variables in there. And we basically used data from May 1st, 2016 to April 31st, 2017 to try to predict who was going to have the events that we were looking for between May and October of 2017. So use this first period as our testing period, our training period, and our second period as what we call our test period. We had data on about 143,000 unique people who had at least one fire department ambulance event or an arrest event during that May 1st, 2016 to April 31st, 2017 period. And our classifier tried to understand who was at risk for a behavioral health involved police encounter in that test period. Our random forest classifier, we really focused on what's called precision and identifying people at risk for a behavioral crisis that involved police. By precision, we mean if we said you were at high risk, how often did this behavioral crisis actually happen for someone like you, during that May to October 2017 period? And we needed that. You want high precision because if I'm going to spend a lot of money going out giving services to Harold, I want to know Harold's actually at a really high risk of something bad happening. And so that precision measure is very important for understanding like the cost effectiveness of some of the interventions that we want to study. And we did another thing that was interesting and useful, which is we performed what are called leave-out experiments. There are lots and lots of variables in the data that we analyzed. And some of those data raised ethical, legal, administrative questions that really had to be addressed. So, we had people's race in there. We had whether or not someone was arrested before. And we had other variables that you might say, you know, it's a little bit problematic to use that variable. Suppose that I have a son and he's having a problem, and I call 911 and I say, you know, my son is really having some sort of a mental health problem, and I need an ambulance to come and help him. Do I really want some algorithm to take into account, well, he's Black, or well, he's arrested 2 years ago? There's some really serious questions there, legal, ethical. So what we did is we performed experiments where we blinded our computer algorithms to some of the problematic variables, and we looked at how these algorithms would perform if we put to the side variables that were not appropriate to use. Because one thing about machine learning is it will use any information it has, and some of that information is inappropriate to use. And so we wanted to look at questions like that. And of course, in 2021 America, you can imagine 50 reasons why that's incredibly important. So what did we find when we compared the models? One thing we found was that when we were looking at a really small group of people, the frequent flyer high user models did basically almost as well as machine learning predictive analytics. If you want to find 150 people in Chicago who are really at high risk, we kind of know who those people are. And these high user approaches are simple to implement, are very transparent, and work pretty well with that really strong segment. But there's some problems with this. One is, some people self-resolve, and you're identifying someone who's not going to have a problem in the future. Second is, of course, we've given up on prevention. Some things, they're way down the trajectory in many cases of things that we would have loved to have prevented at some earlier point. And a lot of the high users we identified just did not correspond very well to interventions that we had available to help people. And so we went to our machine learning models and tried to look at those. And what we found was the machine learning models worked a lot better when we were trying to look at a much larger population. We're not looking at the top 100 people in Chicago. We're trying to look at the top 5,000 people in Chicago. And the machine learning was much better for that larger group. It was also much better at trying to understand people who are not likely to self-resolve and who have issues that actually matched up with the interventions that we had to offer. And very often the machine learning models identified particular aspects of people's trajectories that were also very helpful to talk to clinicians and policymakers about, to say, hey, here's some things that happened in a 911 episode that kind of tell us, wow, I'm really concerned about this person having another one like it, that you couldn't have gotten if you just counted how many 911 calls were made. We did identify some people before they had any 911 calls, say, that involved police, because the predictive analytics was able to identify, hey, this person's at risk. And we identified some really important issues like housing instability and some psychiatric issues that were just really helpful in understanding, wow, this is a person that we want to really focus on, that we would never have gotten through just the high user strategy. Just if you want to see some numbers, we compared the precision of the machine learning models with the high user models. And by precision, we mean if the model flagged you as being at risk, how likely was it that that risk actually was realized for you, in that following 6-month period? And we found that if we tried to identify the top 0.1% of people in Chicago in our data, that the two models performed very, very similarly. But as we enlarged the group, and we went, say, to the top 5%, that the machine learning identification strategies just really outperformed consistently the high user strategy. And so if you're trying to look at a large population of people that you might be able to provide some help for, the machine learning really did do a lot better than just counting how many 911 calls people had. So let me just close with some final policy observations. As I mentioned, we want to appreciate the necessity, but also the limitations of improved police first response in helping people at risk of behavioral crises. I do feel from this work and other work that I don't have time to talk to you about now, we put so much burden on police and other first responders to address failures that are happening in other systems. The mental health system fails. the housing system fails, the addiction treatment system fails, mental health system fails, and then the police become involved. And if the police fail and someone's taking a cell phone video, we say, why didn't the police do a better job? And that's not fair to police. Second thing is, I think the biggest failures for many of the people that we studied might be called the second response, which is no less important and is equally fraught from first response. So the most common tragic failures are less visible than a front page story, say like the Laquan McDonald video. There's not going to be a video of those things. And it's really what happens 2 days, 2 weeks, 2 months after a 911 call is made. Who's following up when vulnerable people require help? Very often the answer is no one is following up. Nothing is happening. There is no second response until the next 911 call is made. Predictive analytics may help us do better than that. We need to do that. But we also need to bring new people, new organizations to our posse. We need social workers. We need co-responders. We need the medical system to help. We can't leave this to police officers, to ambulances, to EMTs, to the other first responders. It's not fair to those first responders. It's not fair to the people who need help. It's not fair to their loved ones who need to have the confidence that they need to know they can call 911 and get the help that they need safely with their loved one, and that they will get the kinds of follow-up and services that they're going to need so that they won't need a 911 call in the future. That's the real challenge. It's not just managing that 911 call better. It's really taking the whole trajectory and finding better ways to help people when they're not in crisis or after a crisis has occurred. So thank you so much for letting me share my work with you. And thank you so much for the folks that filmed this, that did such a professional job and put up with the logistics of my home. And it was great to be with you today. And again, thank you so much.